Good.
You see it, right?
Yes.
Yes.
Okay. So good afternoon to you all, and thank you for having the opportunity to share this case for which we would like to have your opinions and suggestions about the management. So he is a patient, Egyptian 52 years old man with an obesity grade 2 according to the WHO, with dyslipidemia, no smoker and just occasional alcohol consumption, and with a bioptic diagnosis of metabolic fatty liver disease. On top of this, he has some issues with his right knee and some migraine. But the main, I feel some sound, but the main topic is what we are going to discuss now, because back in 2018, he was referred by his GP to perform a CT scan for a mild elevation of GGT and bile duct dilatation at the ultrasound. I think here you should see the CT scan. And a portal vein thrombosis was found with actually a portal cavernoma, causing a compression and dilatation of intradextrohepatic duct. So further investigations for this thrombosis were performed. The thrombophilia screening was negative. No mutation for polycythemia was found. The paroxysmal nocturnal hemoglobinuria was excluded because of no symptoms, and neither symptoms for the Behçet disease or for an IBD. Interestingly, the patient referred a fall on the right side just a few weeks before these findings. So a diagnosis of idiopathic or post-traumatic, if you want, thrombosis was posed, and the patient was put on a prophylactic anticoagulation with rivaroxaban just for 6 months, because after that, the follow-up CT shows no progression in the thrombosis, so they stopped the anticoagulation. At that time, he had no clinical signs for portal hypertension, no esophageal, neither gastric varices, a mild enlargement of the spleen at 16 centimeter, no ascites, and the liver biopsy showing steatosis and portal and periportal fibrosis. So they follow up the patient at the outpatient clinic for 2 years. Till in the 2020, he had multiple admission at the emergency department for a colic abdominal pain. At each time, the blood tests were almost those I brought there. And finally, they decided to do a MRI, cholangio MRI, and after that, a liver MRI. So here is the liver MRI. Maybe it's a little too fast, but here I think you can see clearly that there was a compression of the distal third of the common bile duct caused by the known portal cavernoma. But at that time, they just follow up the patient till 2 years later, again with abdominal pain. Unfortunately, I don't have the blood tests of that time, but just this CT scan, where you can definitely see a worsening of the biliary dilatation. I guess the patient had a cholangitis because they go directly to a RCP. They put a plastic stent. They did biopsy and brushing of the biliary duct that came out as negative for malignancies. Unfortunately, a few days later, the patient developed a cholangitis on stent occlusion. So they had to switch to a metallic stent. And after that, he has a life-threatening complication, which is an hemorrhagic shock due to the biliary varices bleeding. He admitted him to the ICU, he stabilized, and after that, they decided to refer him to another hospital in Switzerland. where they perform a laparotomic cholecystectomy with a Rho and Y hepatico-jejunostomy at 4 centimeters from the biliary convergence. And after a few weeks, the gastroenterologist removed the remaining distal biliary stent uneventfully. The patient recovered well from the surgery till the few months ago, when he was starting complaining again of abdominal pain, some fever, and finally he was admitted in our ward in September with a cholangitis, actually fever, abdominal pain, CRP at 100, GGT almost 600, and the blood cultures were actually negative. So we gave him just an empiric antibiotic treatment, and we repeat the MRI. I know the quality is suboptimal, but here you should see clearly the biliary stenosis here, while here down there is the hepatico-jejunostomy, which is definitely not stenotic. So the patient was discharged with carvedilol and ursofalk twice a day. So here we have the complete timeline of this history, and just a sum up for this case, we have a young man with a metabolic fatty liver disease and a cirrhosis child A. He had a portal cavernoma on a portal thrombosis, probably due to a trauma. He has already underwent an hepatico-jejunostomy at 4 centimeters from the biliary convergence. And at the last endoscopy, which was performed in August, he had no esophageal varices and a reactive gastropathy with no intestinal metaplasia, maybe due to a biliary reflux. And the liver biopsy shows a portal and periportal fibrosis with initial formation of septa and perisinusoidal fibrosis grade 3 with a fibroscan of 8.2. And the patient is having recurrent cholangitis. So we were wondering what to do with this case of symptomatic portal cavernoma cholangiopathy in order to decrease the portal pressure and to prevent further cholangitis. We were thinking about a shunt, like an hepatorenal shunt, but actually we would like to know what you think about and what would you do. So thank you for the attention, and I'm looking forward to your suggestions.
Thank you, Isabella. So we asked for advices for this problem of recurrent portal hypertension biliopathy in a patient that has already been operated.
Please, could we know what is where is the level of stenosis now? It is not at the level of hepatojejunostomy. It is above this, or where it is?
The stenosis is higher. We can show the images back. So the anastomosis was convection at about 4 centimeters below the convergence, and at the last MRI, the stenosis looked much higher. There are at least 3 centimeters of normal distal hepatic duct before the anastomosis, and the anastomosis itself didn't look stenotic. This is a not contrast enhanced phase, but actually we could see clearly that there's still cavernoma that goes in intrahepatic portal circulation, and is probably the cause of the new stenosis.
Yes. Can I speak?
Of course.
I think that is a Hiller stenosis now, of course, but in fact, this patient had a treatment of the biliary stenosis, but not the treatment of the etiology. In fact, it was not really the point to treat the biliary, but it's not your fault. It should have been first the problem of the portal cavernoma. So maybe if I I have this patient, I would try interventional radiology. And it is possible because this patient has a portal flow into the liver. So we could do a punction over this portal right, for example, the right portal vein, and trying to recanalize the portal flow with a stent. It is possible now, and I had a case like that treated by interventional radiology to make regress the portal cavernoma. So maybe, I didn't see very well, but maybe it is possible now to try this procedure, interventional radiology, to restore the portal trunk.
But do you know if there is a fibrosis of the truncal, of the portal vein? If this possibility is effective, or it depends.
We have discussed that. We have discussed that on the entry CT scan when the patient came back with the last episode of cholangitis, and our radiologists were quite. They were not so sure of the possibility.
To treat.
I think I would have pushed them a little.
I am sure you listen to me.
Yes.
Yes, I am sure I miss almost all. For the sound of my computer was terrible. Now I went to my iPhone, but I miss a big part of this. Only one thing I ask, it is what you call a post-traumatic portal thrombosis.
Actually, we don't know the cause of the thrombosis. The patient was screened for hematology by the hematologist, and we didn't find any favoring factor. This is a quite sportive patient that was used to do contact sports, and he reported an accident. So we thought about maybe a post-traumatic cause, but actually is not clear at all why he did develop the portal thrombosis at the beginning. It was found already with the cholangiopathy.
Well, of course, there is the portal thrombosis, but it's strange for post-traumatic by a traffic accident. The portal thrombosis due to a traffic accident. Personally, I never heard about that. But I don't know. But anyway, the portal thrombosis exists. But you know the extension. It goes to the branch of the portal trunk.
It goes from intrahepatic, from the first jejunal branch to intrahepatic, actually.
Even intrahepatic. But now, what proposed Laurence? Laurence, you propose to repermeabilize. I don't listen very well. Laurence, you said that you propose to repermeabilize the umbilical vein. This is what you said.
No, not the umbilical vein. In fact, they can puncture because can we see the whatever the MRI or the CT scan, because I saw some branches into the liver. Maybe not. This is the biliary MRI, not the biliary, just the normal. Maybe this one. Yes. Okay, you see there is I think that it is possible to try to puncture the big vein here. Again, upper, not down, upper. Here, and to try to go into this vein, which is not, of course, the portal vein, and try to put a stent into the mesenteric flow This is possible. They can do now a lot of things, but they had to try. There is there a vein? There is a splenic vein, isn't it?
Yes, the interventional radiologists, they do now transsplenic repermeabilizations of the portal vein.
It is possible either this way or transhepatic. They can do a lot of things now interventionally. Maybe it's not possible, but they should try, because it would be very difficult. Splenorenal, I'm not sure that the splenorenal shunt will solve the problem.
Prashant?
Yeah. So I just want to say, Alexandra, in order to incorporate what both Professor Shish as well as what was mentioned, I think that the order of treatment has been completely the opposite way here. It should be vascular decompression followed by any biliary intervention.
Of course.
But that's a time of the past. I would really want to know or delineate the vascular anatomy here. See what is it? Is it left-sided portal hypertension? Do you have the thing draining into the mesenteric circulation with which you could sort this issue by doing a mesocaval shunt instead of doing a line-renal shunt? What Laurence was talking about of PVR tips or of dips, that means going through the liver or coming through the splenic vein and trying to recanalize. We've done it for type 3 and type 4 portal vein thrombosis before transplant in order to prepare the patient for transplant. That is another option. But I would say that this is probably a simple case of EHPVO from something originating from maybe neonatal sepsis or something. Patient has had a long-term portal vein thrombosis. There is extrahepatic portal vein obstruction.
Oui, merci, c'est Thierry.
There is EHPVO and it's a long-standing portal biliopathy. For me, what is important here is I would still try to decompress. And for decompression, maybe because there is nothing inside I don't see much inside the liver, unfortunately, to come via the liver, to come into the portal vein and try to recanalize it. So probably you may have to go back to doing a mesocaval shunt here, because it may be right-sided portal hypertension which needs to be released and not the left-sided portal hypertension. So I would do a delineation of the vascular anatomy by doing a good triphasic CT angio to see where exactly and what vessels are available. And that probably may sort out the issue. In addition to that, I would also need to know what is the status of the liver parenchyma at present. And I would not hesitate to redo a biopsy at present, because I would need to see whether this patient has already started developing, evidence of secondary biliary cirrhosis. Because it's been a long time, you've done interventions, you've had obstruction to the bile duct. So he may ultimately land up very soon, if he is going into secondary biliary cirrhosis, you may not be able to sort out this issue and probably may land up ultimately in a transplant. So these are two things that I would think of at present: vascular delineation and knowing what is the status of the liver parenchyma.
Yes, I agree with Prashant about, I think we must know exactly the anatomy of the portal branch and the portal, what is the cavernoma. In the old time, we were doing what was called arterioportography. That means by arteriography, the injection in the mesenteric artery and also in the splenic artery, you may have a very nice and better than by the CT scan. You have a perfect anatomy of the portal division, the portal distribution. I think that we must know exactly what are the anatomy of the cavernoma, seeing the connection of the intrahepatic branch of the portal vein with the trunk. I think this is important. The second point is that what is exactly the nature of the structure of the bile duct? You think it is the biliopathy? What is exactly the nature of the structure of the bile duct?
We think it's an extrinsic compression by the cavernoma.
but you are not sure.
He had already a spyglass at the beginning of the history when he had a distal stenosis, actually, and he didn't have any signs of malignancy. And after that, he had the biliary anastomosis. But actually, we think this just the extrinsic compression by the cavernoma. He hasn't any radiological sign of malignancy.
You said that the portal thrombosis was due to the trauma. You know, it is more frequent by an abdominal trauma to have a rupture of the bile duct, that of the portal vein. That means that it could be a stricture, not only the compression by the cavernoma. And these are in the paper that we published in Paul Brousse, there are association of both stricture, a real stricture of the bile duct and all the portal trunk. I think also for this we might be sure if it is that.
We're not sure about the origin of the portal thrombosis, so it was supposed as a differential diagnosis, the trauma, but we are not sure about it.
Are you really sure that it is, I would say, the cavernoma which is responsible of the upper stenosis? Because usually is the main biliary duct which is concerned by compression of the portal cavernoma. It looks like that it is inside the liver, your new stenosis. And so it's very infrequent that stenosis may appear intrahepatic, you know, in relation with the cavernoma. This is at least my experience. I don't know if we share the same experience with all the compagnons here, but usually it's the main bile duct. And so to say now there is no stenosis of the hepatojejunostomy and the new stenosis is inside the liver, this for me it's very, very infrequent. But if we prove that, I would agree that a portal decompression should be done either by interventional radiology or by mesocaval or splenorenal shunt in a way to treat the cause.
Mm-hmm.
But I'm surprised by the level of the stenosis.
Yeah, I can try to show better the images.
May I come in?
Of course, yeah.
Hello? Yeah. So what Rennie said just now, I think we have to compare the MRCP before doing the hepatojejunostomy with the current MRCP to see exactly where you have done the hepatojejunostomy, because you have done the hepatojejunostomy 4 centimeter below the hilum, yes. Right? Mm-hmm. Okay. So why the supra anastomotic area of the bile duct got stenosed? Is it recurrent cholangitis which is responsible for the stenosis, or is it a cavernoma which is causing compression? Now, to get the answer, you have to have a CT photogram, current one. Okay. You have MRCP, but you don't have a CT photography to demonstrate the cavernoma status in that area. And is it causing compression? Because, as Professor Bismuth said, what paper has come out from Paul Brousse, and we have, with our own experience, the narrowing in extrahepatic obstruction, that is portal cavernoma, can be indentation by the dilated collaterals, or it can lead to ischemic stenosis of the bile duct, that is stricture. The strictures don't open with any of the anastomosis, okay, or by portal decompression. If it is a compression by the dilated collaterals, then portal decompressive surgery works well. So we have to establish, is it a fibrotic stricture versus indentation in the suprahepaticojejunostomy area, because that is the problem. So first compare the MRCP before the hepaticojejunostomy was done with the current MRCP to see what is the condition of that portion. Second, we need to have a CT photogram current position. You are showing what the previous one. Okay. Now, if the previous one status is same as today, then that vein which we are seeing going into the liver is actually a bridging collateral, one of the bridging collateral. It is not a portal vein. Okay, we often see it. Now, the option for decompression, yes, one can do the splenorenal shunt. It will decompress because through the collaterals in the head of the pancreas and will decompress the cavernoma. We have done that in the past. Okay. So currently, we have to assess whether this narrowing of the bile duct, which is above the hepatogenostomy, is due to fibrosis, or is it because of the compression by the portal cavernoma. So that is the first thing. Then you can take the second step. Now, as far as the fatty liver and the inducing fibrosis, that has to independently assessed. I don't think it is secondary to the biliary cholangitis because it was there right in the beginning in 2018 when the first time patient presented. So that's my opinion that we have to have a CT program currently. You can show MRCP, which was done before the hepatogenostomy and the current, so that we can compare the two.
Okay. So this is the only contrast images that we have now. Is the last images
Can
of
we
the
have
patient.
MRCP before the hepatogenostomy in 2023? Yes. MRCP.
This was before the
and the current MRCP, so that we can compare the two. Yeah. So, yeah. Just stop. Please stop there where we can see the anatomy completely, the extrahepatic and the enterohepatic portion. Go.
Here, the stenosis looked distal.
Yeah. So at that time, the upper part of the bile duct was dilated, so it was not affected by the stenosis. Okay. And now you compare this with the current MRCP. Yeah. So here the supraduodenal portion of the bile duct was quite dilated. So the obstruction was in the lower CBD. And now we see the current one.
This is the current one. So actually, we saw the stenosis here at this level. Here are the
that is left up.
The cavernous, and this is the distal part of the bile duct before the anastomosis. The anastomosis is much lower.
Yeah. So in portal biliopathy, it is known that it can affect the one part or it can affect the multiple, give rise to like a PFT type of structure. Okay. And sometimes it involves the hilum. That's what it is showing. It is showing the left duct involvement in the narrowing. Okay. Now we should have a CT photography to see if we see the indentation of that part of the duct by the dilated cavernoma. So if we see indentation, then a portal decompressive surgery will work. Okay. If we don't see any indentation, rather thrombosis of the portal cavernoma, which will give rise to ischemic stenosis, then the bypass has to be done higher up in the dilated left duct here, where you are seeing dilated left duct. Okay. So we have to have a CT photography of at this time, and then compare these two images.
Okay. Thank you. We come back with better images.
Just one comment that to begin with, what Prashant was saying is right. If this patient would have come the first presentation, the surgery should be offered, would have right in the beginning, 2000, would have been a proximal spinal shunt, side-to-side spinal to decompress that cavernoma. We do not have allowed the 70% of the cases it works. Required a bilioenteric anastomosis. Other studies which have been published from India. So that would have been the approach in the beginning. But now that stage is gone. We are in second stage. So again, we have to reassess whether it is going to work or not.
I think, Alexandra, another thing is that this is a young individual, right? So you have to think about a long-term solution as well for this particular individual. Yeah. And that's the reason why I said that if we are now at a stage where we've already reached the stage because of the recurrent cholangitis to a stage where this patient is having an effect on his liver parenchyma, secondary biliary cirrhosis type of picture, and it's progressing and he's had these recurrent episodes, then sometimes, I have to think earlier rather than later that this patient is going to go for a transplant. Maybe not necessarily waiting for that stage where he decompensates, but here the quality of life, recurrent cholangitis, episodes of sepsis, chances of going into cholangitis with septic shock, all these things come as one of the considerations when you think about how you want to go ahead, especially if the patient is young. So that's the reason why I brought up the thing about that maybe that he's going to need a transplant very soon if we are not able to sort this out.
Thank you.
Okay.
Would you like to go on with the second case?
Yes, sure.
Yes, we have a case, and Dr. Panettiere is going to present a case. It's a case of liver metastasis, colorectal. So we have the pleasure to share with you the possible treatment.
Hi, good afternoon, everyone. It is a pleasure to present this case in front of you today. So can you see my screen?
Yes.
Yes.
Okay. Okay, so this is the case of an otherwise healthy 68-year-old man. His clinical history dates back to June 2020. I mean, the beginning of his clinical history dates back to June 2020, when he presented with positive fecal occult blood test that led to a colonoscopy that demonstrating a nearly obstructing mass 20 centimeters from the anal verge, which was confirmed to be adenocarcinoma. At this point, he underwent staging chest and abdomen CT scan showing multiple bilobar colorectal liver mets with multiple bilateral cysts.
No.
So this is the baseline CT scan, which was done in July 2020. The metastases are highlighted by the red circles, while you can also see the cysts. You can see why there is an involvement of all the liver segments, including the caudate lobe. We have very deep metastases. Here we have a relationship with the right and middle hepatic vein. And there is also a critical anatomical relationship with the right secondary portal bifurcation for a total of 38 colorectal liver mets. It is important to note that at this point, and for many years, this patient has been managed at an outside institution. So when this CT scan was done, we were not in charge of taking care of this patient. So at baseline, his CEA was 47. And the decision was made to perform an upfront laparoscopic sigmoid resection, which happened in September 2020, exactly 5 years ago. Probably the reason for that is that the tumor was, the primary tumor was nearly obstructing and the liver disease was deemed unresectable. So let's break down the pathology result from his sigmoidectomy. So it was a mucinous adenocarcinoma, poorly differentiated, PT4A, PN1C, MMR proficient, KRAS mutated, and ATM and FANCA mutated. Please keep these two mutations in mind because they will key to understand how this case developed, and we will discuss about this later on. So this is a CT scan obtained after 12 cycles of FOLFOXIRI bevacizumab. You can see how well the metastasis responded in terms of size and number. So we could demonstrate there was a partial response with 15 disappearing colorectal liver mets, and also morphologic response, which is typical of metastasis from mucinous colorectal cancer. This scan was obtained in April 2021, and at that time, CA was 4.1. So the patient at this point was totally against surgical options. So it was totally against it. So what the clinical oncologist could do at that point was to continue with systemic treatment. And in particular, they started maintenance chemotherapy with Digramon and bevacizumab. So this CT scan was taken 2.5 years after the start of maintenance chemotherapy. So here we have a radiologic complete response. This is October 2023. And at that point, CA had totally normalized. So from 47 at baseline, now it was 3.4. So what happens now is that the patient continued with maintenance chemotherapy for other 20 months. So totally, the patient was on maintenance chemotherapy for 4 years and 2 months. So in June 2025, 2 new colorectal liver mets became visible, one in segment 4 and one in the caudate lobe. The patient was referred to us at this point. CA was 5.4, and our medical oncologist decided to restart oxaliplatin-based chemotherapy. He now received 4 cycles of FOLFOX plus bevacizumab, and disease is completely stable. So my question is, what would you do now? Would you consider resection at this point? But before we dive into the actual discussion, I would like to show you quickly 2 papers to give you more perspective. So this is an abstract. It was presented last year at the ESMO conference by the medical oncology team of our university. The background is that homologous recombination and DNA damage repair alterations are associated with sensitivity to platinum agents in several malignancies. This topic has been traditionally under-investigated in colorectal cancer. Our oncologists identified 306 patients with metastatic colorectal cancer, 19% of which presented with homologous recombination and DNA damage repair alterations. Among these alterations, we have ATM and FANCA, which are those 2 genes that I showed to you at the beginning. So basically, this patient is a carrier of an HR-DDR alteration. So in this population, patients with HR-DDR altered metastatic disease, it was seen that oxaliplatin-based chemotherapy was the only variable independently associated with significantly longer median progression-free survival, suggesting that carrying one of those mutations makes patients more responsive to treatment with oxaliplatin. Here is another paper published by Professor Caputo in 2018 addressing the issue of disappearing colorectal liver mets after pre-op chemotherapy. So the authors identified 82 patients with 111 disappearing colorectal liver metastasis on CT scan. But when liver-specific contrast-enhanced MRI was performed, actually 58% of those metastases were still there, so they were not really disappeared. So in this study, When disappearing colorectal liver mets were detected with contrast-enhanced MRI, the probability of residual disease was higher than 70%. But when disappearing colorectal liver mets were not identified at a contrast-enhanced MRI and were not identified intraoperatively with ultrasound, residual disease was just 7%. So results from this study suggest that if colorectal liver mets disappear, even at MRI, there is a high probability that there is a pathologic complete response. So just gave you these 2 hints to spark discussion. Thank you for your attention.
Thank you, Elena.
Okay, thank you. So if I may do some comments, I think it's a very interesting case. Unquestionably, this patient has 2 good prognostic factors. The fact to respond very well to chemo, and the fact that we are now at more than 5 years from the beginning of the disease. So, but what you show is that when we stop chemo, finally we have a recurrence. And it is very unlikely that such type of patient with 38 liver metastasis may have a complete response of all the lesion. So on a probabilistic attitude, I would say that the chance of a complete pathological response is very, very low in this type of patient, but it could be. And it could be. So the attitude could be we stop chemo, and it has been done, whether we have no recurrence at all, and we continue hoping that this patient has a complete pathological response. But indeed, it's not the case because the patient has recurred. And so seeing the beginning of the disease, if we want to offer a real chance of cure to this type of patient, is not, I would say, to continue chemo, is not to propose resection, but I would say, unfortunately or fortunately, I don't know, you choose the term, it's liver transplantation that could be the ideal treatment for this type of patient. Because if you go to resect, I have had some of these patients going to, I would say, resection of emerging new lesion after stopping chemo and so on. But I would say you wait a little bit and other lesion will reappear. So in view of the initial imaging, if we want to propose a cure to this patient, it is transplantation. So this is my opinion.
Well, René, thank you very much. But we have actually already proposed the first, when we first saw the patient, that probably the transplant was the best treatment to consider.
There is a problem of connection.
He is against, because, you know, he is feeling no more connection. Can you see me? Can you hear me?
Yes.
Can you hear me, René?
A bit better.
Okay. So the patient, thinks that I have already had a very nice response to chemotherapy, so he's very, very reluctant to consider transplant. Actually, he's against. Not very reluctant, I have to say. So the question that our oncologists gave us is, can you consider to resect these 2 metastases? So, in this context, I agree. It is very difficult to consider resection. Also, if we have to consider that the probability to complete response, pathologic response, is quite high. Also, considering that very special mutation, very special situation, which is very, which gave the possibility to have such effective response. So this is the question, to resect these 2 ones, but you have already done, I mean, your evaluation. So.
But anyway, the patient accept resection. He refused transplantation, but would he accept resection, or
yes,
he continue to negate any possibility of surgery?
No, now he would accept resection.
So anyway, at that time, if we abandon the possibility of transplantation because the patient refused, this is his freedom, we can go to cytoreductive surgery. So
exactly.
this is the second option that indeed it's much less, I would say, potentially curative, but why not? And at that time, you operate the patient, you remove all the lesion you may have in the liver, of course, the two sites of recurrence, but also all the other lesion, and we may offer the patient, I would say, a sort of cytoreduction with the aim to prolong the survival. Although liver transplantation could be the best, but anyway, you should adapt to also to the wishes of the patient. Unfortunately, I would say, but anyway.
Yes, because the oncologists already used many, I mean, drugs. I mean, many cycles. So if under the last one we have I mean, other two, let's see, new liver metastasis, the only possibility is consider surgery. But yes, this is I mean, yes, I agree with you. Just we can consider this a cytoreductive surgery. In this feeling, we can consider and we can propose.
You know, it is theoretical to say a complete cytoreductive surgery. For, you know, several metastases will escape. You will not find them. It is very difficult to find them when they disappear. So to say complete cytoreductive is theoretical. Really, I think the surgeon don't have to change his mind. Personally, I am convinced for this patient.
C'est Henri Bismuth.
Sorry. I don't know.
Can you close the microphone, please?
I don't know. Okay. I disappear from the. I don't know where I am.
No, we see and we listen to you now. Good.
Okay, it's good now.
For us,
you listen to me.
Yes.
Okay. So what I say is that first, it is theoretical to obtain a total cytoreductive surgery in these patients. I think at the beginning he has 19 liver metastases. This is correct? 19?
34.
38.
38. How to remove, you know, it is quite impossible. And in the future, the risk is very high that even a very small may reappear. I think that today, and René Adam right in the beginning, that today the best option is liver transplantation. Now, personally, as a surgeon, I will not change my mind if the patient refuses. And I will try to convince him that really this is the best solution. He accepts surgery, he refuses liver transplantation. I think we have to expose to him what is the risk of doing each treatment. Apparently, he's young, he's in a good shape. This is correct now?
Yes.
So we must convince him. You know, I experienced this kind of patient in my life. Patient was refused and prefer another treatment. But we cannot go to the patient. We cannot accept the solution of the patient and reinforce him, saying, okay, we will do this treatment for you. You ask for this treatment. No, I will say to him, I cannot do that. It is impossible. It is very risky. You will do surgery, a very important surgery if you try to remove, let I say, 10 or 15 liver metastases. But are you sure you will cure the patient? I doubt. I doubt. So I will not go in the side of patient. I will try to convince the patient that liver transplantation today is the best option. René Adam is right by proposing this. You know, what is the risk? What is the risk of liver transplantation? The risk in these patients, if indeed, when you do total hepatectomy, you remove all the risk of recurrence in the liver. The only risk is remaining liver tumoral tissue outside of the liver. And this, no treatment possible for that. That means you give to the patient the best chance of cure if all the tumor are inside the liver. This is the best for him.
Tim Pollock want to give a comment. He's a specialist of the missing metastasis.
Yeah, I don't know about that, Renee, but I know I completely agree with you, Renee, and Professor Bismuth. I think that liver transplant would definitely be my first option. I wrote in the chat room, I don't think it's unreasonable, given the very long, natural history of his disease of 5 years, like you mentioned, it's only intrahepatic, to take him to the operating room and to remove the disease that is visible. I would obviously, I don't know if you got an MRI beforehand, because there's always a difference between what is missing and what is truly disappeared. And so, MRI is much more sensitive. But then we would place a pump. The data from Memorial and other groups has clearly shown that the PR and the CR rates are much higher in the setting of a pump. So the only way I would operate on this patient is by resecting the person and putting a pump in. My first choice would be transplantation, but my second choice would be resection and placement of a pump.
Don't you think, Tim, that the liver is very altered by all this chemotherapy to do intra-arterial chemotherapy now?
No. I mean, what do you mean? What do you mean altered? I mean, the anatomy hasn't. I don't think there's like new vascular shunts in the liver, and I don't think the arterial anatomy has changed. And in many settings, the pumps are used in an adjuvant setting, so patients have been heavily pretreated. I'm not aware of any literature that demonstrates, the decreasing efficacy of the pump.
No, it's not a question of efficacy. It's a question of toxicity, because we in France normally we use a lot intra-arterial with oxaliplatin, and we have to stop that because nodular regenerative disease and hypertension, portal hypertension happens after this chemotherapy. We have a lot of problem in that conditions. And I would add that I would definitely not operate this patient, because it's very difficult to look for a metastasis in those type of liver after 5 years of chemotherapy. I think the parenchyma is really, really difficult to explore, and even difficult to manage operatively. So
yeah, no, I completely agree with that. I think it's a fool's errand if you think you're going to find all of these, and I think the liver will be, steatotic, and it'll be very difficult. I don't know as much about the toxicity. I mean, we, in our pump program, we have some level of toxicity, but our medical oncologists have been able to manage it. And so in our hands, it wouldn't be a contraindication for putting a pump in.
Interesting.
What happened?
So there is a way to conciliate, I would say, all the opinion. We agree transplantation is the best. If you convince the patient, is okay. If you don't convince the patient and trying to give him what may be the best treatment could be to resect I would say, the recurrent lesion today, also to remove all the old lesion, possibly in pathological complete response. You will have the information if you remove all the scars of the old metastasis in a way, because the optimistic way is to say this patient has possibly a complete pathological response of, I would say, 80% of the lesion and 20% are potentially active. And by removing, I would say, these potentially active, possibly you may be as optimal as possible. But I have a patient who stick absolutely with your patient. He is, because he's still alive, 50 years old. He was randomized, unfortunately, in the group of transmet of chemotherapy, but his chance was he responded very well to chemo. And when we did chemotherapy, all the lesion, we go to radiological complete response. But when he stopped it, 6 months after, the new lesion reappeared. And I was obliged to reoperate this patient because at that time, as it was randomized in the non-transplant group, I was trying to, he is 50 years old, so I remove recurrent lesion. I remove, if I remember well, 3 to 4 lesions. Now, new chemotherapy, all was okay, but stop chemotherapy, and 4 months after, 3 other lesions. And so, new chemo, complete radiological response, but now he has lymph node in the mediastinum, because I have think that now that the result of transmet are known, I have had an idea to transplant this patient. But unfortunately, we are now at 5 years from the randomization, and he developed lymph node metastasis in the abdomen, retroperitoneal lymph node, and also in the mediastinum. So we lose the chance to be transplanted, and so the patient will continue on chemo. So this is a final outcome of the majority of these patients, even responding very well to chemo. But conciliating the different opinion, if the patient refuses liver transplantation, what you can do is to remove the recurrent lesion now, also to remove possibly the sterilized one, and to give, why not, adjuvant intraarterial chemo. Because it is now demonstrated, it is a randomized study done in France by the group of Gustave Roussy, that by giving intraarterial chemotherapy, we prevent much more the risk of recurrence after resection of more than 4 lesions. So it is a way to give possibly the best treatment instead of transplantation. Resection plus intraarterial chemo on an adjuvant setting.
Thank you very much. Thank you.
And you think, René, I speak to René, you think that really you will propose this to the patient with 42 liver metastasis? For, you know, after the beginning of the story during 5 years, each time you stop the chemotherapy, they have new tumor. I think, you know, I will not engage myself in this road. I will refuse, really, I will say to the patient, the only choice is liver transplantation.
I will converge with you, Monsieur, about the fact that we should try to do our best to convince him for transplantation. Yes. But if he refuses, rather than to do only chemo, possibly to propose what may be an alternative, the best alternative to transplantation.
But, you know, I will not propose this to the patient. I will say to the patient, I cannot treat you. Go to see the surgeon. I cannot accept, you know, this is a kind of ethic. I refuse to go to the idea of the patient. We say to the patient, you are a best doctor than me to choose your treatment. I refuse. I refuse to give your treatment that you decide yourself. You are not the doctor. I am the doctor.
You are the master.
No. But I did that. I did that. Sometimes, you know, patients say, no. I want to have this kind of treatment. I say, no. If you want to be the doctor, you treat yourself, but not me.
Okay.
Really, I don't think that this patient may be cured by chemotherapy. You know, we have the experience. It recurs every time. Of course, we may hope to have a miracle treatment in the next month. This is possible, of course. This is the miracle. But apart the miracle, today, the only option for cure is liver transplantation. And the risk to him for a liver transplantation is almost the same that liver resection. You have to explain this to him. The risk is the same. So it is not reasonable for him to decide for resection and not for transplantation.
Okay, thank you very much.
I have just a question, Felice. I don't know the reality of liver transplantation in Italy. So I agree with the proposal from René. But in reality, how is the availability of liver grafts in Italy? And would you go to some kind of technique like a rapid technique or a living donor? What would you do as liver transplantation in this case?
No, well, I think that we do not perform liver transplantation by me. I mean, in our unit, but the general situation is that the rapid technique is very rarely used, and the classic transplantation would be the choice. I mean, in our center, in our hospital, but also, of course, in the other ones in Italy, and with basically with the principles of the Transmet. I mean, because it is expanding the number of patients transplanted for liver metastasis.
Yes, we agree. But do you have, in practical, do you have livers available for this in Italy?
Well, actually, in Italy, there is a large use of the machine, the perfusion machine, and the possibility to reuse many marginal livers for transplant. It has been more and more frequent. Just 2 weeks ago, I have the chance to discuss with colleagues, transplant liver colleagues, rate of reconditioned livers in Italy is extremely high, and it seems I mean, an increasing possibility, an increasing chance to propose, I mean, liver transplant also for this patient. So it is not a big problem in the right context. I mean, and Transmet gave us the right, I mean, context in which
exactly,
we have.
But we give this message of hope to our patients, and I'm not sure, René, that this message can be given broadly in all countries. So in Belgium, for example, we are fortunate to have livers that we could use for this purpose. And we try in Belgium to regulate the availability of those livers. But I'm not sure this is the case in every country. There are many countries where there's no availability of livers.
I agree, but of course we should adapt the means to the objective. And of course, some countries do the best, some countries do a little bit less, and we should continue chemotherapy, but we can also, I would say, do the liver transplantation a little bit earlier, in the history of the disease, rather than to wait for the third line of chemo, 50 courses of chemotherapy. Okay, so we will.
Yes, no, but my question is, should we take in those patients which are usually in a good health transplantation risks as left liver grafts or rapid technique, because this increases the morbidity and the mortality of those liver transplantations.
I think, of course, the best, as usual, is a whole liver. But when we cannot use a whole liver because of lack of organ, at that time, possibly much better to accept such type of things. I put, for the rapid technique, I will put some reserve about this technique, which is not done very broadly, and the first results are not so promising as it has been expected. So rapid, we always say rapid technique, but very few people are doing it, and those who have done it have not so good result, and you know this as well as me. So rapid technique we put apart, but a split liver, a marginal donor, a whole liver, a living donor, all these possibilities should be explored, of course, much better rather than not to do transplant.
Yeah.
Valerio, if I can just make a point, you said left livers, you said rapid, you said left laterals, you said small liver sizes. I think, you know, what's also important for us is to convey the message, just like Professor Adon said, that, you know, you should go, the means should be defining, you know, or your objectives probably should be defined by your means. It also depends who's doing that living donor liver transplantation. If you have a center who is doing 300 transplants, I would say, why do you want to give an inferior result to a patient who is having colorectal liver metastasis? You should do it with a right lobe. There's no question. I think there is, you know, there may be people who may argue with me that you go on the side of the donor and try to maintain donor safety. In a person who is doing, or in a team or an institute or a country who is doing regularly living donor liver transplants with right lobes of the liver, and the donor morbidity is as low as that for a left lobe, or maybe slightly higher, and not really going into grade 3 and grade 4 morbidity in the living donor, I think you should do what is best for that particular patient. So why do you think of a marginal liver or a small size liver for a patient with colorectal liver metastasis? Ultimately, you need a positive result of the liver transplantation. So I think that's also a message, since we are addressing a bigger international forum here. I think it's important also that ultimately one should think that the outcome of liver transplantation also matters. So you should give the patient the liver he deserves. So I would not stick to doing only left lobes or rapid techniques for which results probably are inferior, but I would definitely think of giving the best result to the patient, of course keeping in mind donor safety. Yes.
Of course, I totally agree with you, Prashant. It was to discuss of these issues, because it's always the issue when we have scarcity of livers. We have to go further, and so it's further discussion.
Can I just make a comment about that? I think that scarcity of livers is a good thing, because otherwise we would, to my opinion, push the limits of liver transplantation for colorectal metastasis, because we have to remind that the recurrence after liver transplantation is very high. So we have to my opinion, we have to work on the selection of the patients. And for example, and René, you said that after a long period of metastasis, it's very frequent that we have extra hepatic metastasis, sleeping metastasis, because when you have a lot of cycles of chemotherapy and a liver exclusive disease, well, I have exactly the same experience than René, with patient with 4 or 5 years doing well in the liver, and we decide to transplant, and well, there is extrahepatic disease, in fact. So let's remind that liver transplantation has morbidity and mortality, and we have to inform the patient that recurrence is very frequent after liver transplantation. Remember the TransMet trial. it's very frequent because we have to work on the selection, the best selection to find the good indications. Because if there is no scarcity of livers, well, we open the Pandora box, to my opinion. And I would just ask Felice why this patient refused surgery always. Why?
Well,
Did you
always, I don't know, because as Dr. Panettiere said, he, at the beginning was not managed in our unit. So we had the chance to talk with the patient the last months, and already he accepted the possibility to be resected. So I will go back to the patient. I will try to propose the transplant, because
I would say that at the beginning he refused, but he was right, because it was not an indication of resection. And maybe we have to see now why he accepts, because he thinks, to my opinion, that it's the only way to be cured, but it's wrong. It will not be cured. So maybe,
yes, but actually,
I agree with
if
Professor Bismuth, I wouldn't accept to resect him.
Yes.
If we had seen the patient before, we had proposed from the beginning with 38 liver metastasis the transplant, of course. But actually, the feeling, I mean, towards surgery for this patient, I mean, is not good. So, of course, we will try to convince that the transplant it's actually the best choice for him. I mean, considering all the history, all the great results of the chemotherapy, the extremely high number of liver metastasis, and I agree. But that was the question of our oncologists. Why we cannot resect, propose to the patient to resect these two liver metastases? So it is, I would say, a quite unusual question in this context. So it was very interesting to have to get your opinions on this patient.
You can say him that it is the top of the iceberg.
Yes.
Right.
Yes. Of course. Thank you very much.
Yes.
Thank you.
I think there are no other cases. If I'm right.
Angelica?
Yes, Professor.
There is other cases?
I don't think so.
Okay. No problem. Yeah. Very, very interesting two cases. It's very nice. And we have no answer for each of them.
Right.
That's
but
the best
illuminating
answer.
discussions.
No, sorry, I come back what I say. I don't speak about this patient, but I speak about our position. You know, it happens often that I refuse to do to a patient the treatment that I cannot accept myself. It is impossible. I refuse. I say to the patient, I cannot treat you. I cannot treat you. And since the beginning, I remember I was a young surgeon, and a patient came with a very low cancer of the rectum. And he said, a surgeon say he will keep his anus. I said, it is impossible. You see, he said that, he said, I will try to keep, I am not sure, but I will do that. I was sure it was not possible. I said to the patient, no, it is not possible. He went to the other surgeon. And what happened? Of course, he has a total ablation of the rectum. That means the surgeon was lying. He was lying. He was saying something that I cannot. So I prefer to say to the patient the truth and to say, no, it's not possible. Today, and René is right, and Prashant also, the best chance for him, of course, it could have, as say Laurence, metastasized outside of the liver. But at that time, there is no resection, no transplantation. There is no problem for that, no possible cure for that. But today, the chance for the patient to be cured is liver transplantation. So I will not propose anything else to him. Okay, this was a short comment. Okay, so we stop now the session.